What we used to think was a healthy tan turns out to be the possible beginnings of the most common form of cancer in the United States. Skin cancer, including the most serious melanoma. Shining light on skin cancers. The doctors are on call tonight.
Here comes the sun. Here comes the sun. And I say, it's all right.
Funding for On Call is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call, starting its 11th year of opening doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
Welcome to On Call Television. Tonight our topic is skin cancer. Now these cancers seem to be about 4 times more common in Australia and New Zealand because of the ozone hole located over the Tasman Sea and the excessive UV light that shines down on people living there. But even where there is less UV exposure here in the U.S. and here northern part of the U.S., every year more than 3.5 million cases of skin cancer are diagnosed. Skin cancer is the most common cancer in our country, affecting at least 1 in 5 Americans one time in their lives. The most common kinds of skin cancer are basal cell and squamous cell cancer, but on the rise is malignant melanoma. This less common cancer is particularly dangerous due to its ability to spread through the bloodstream, and it is worth talking about since the early diagnosis is the key to treatment. Here to guide us about the kinds of skin cancer, how to recognize, diagnose, treat, and prevent them are the dermatology physicians Carmen Schwartz and Jim McGrann. Dr. Schwartz grew up at Esteline and went to undergraduate school at South Dakota State University, Raw Rabbits. She did her medical training at Sanford School of Medicine, did a transitional internship at Sanford and her dermatology residency at the University of Illinois College of Medicine in Chicago. Dr. Jim McGrann is originally from Watertown, had his undergraduate training and graduate school at medical school at USD. Raw Coyotes. His dermatology residency training was first at Marshfield Clinic and University of Wisconsin, and then the Mose training at the University of Wisconsin with Dr. Frederick Mose himself. He moved to Sioux Falls and started the Dakota Dermatology. All of you at home are also participants in our discussion tonight. We are pleased that you are watching and know that you will take away valuable health information regarding skin cancer, the warning signs, how to reduce your chances of developing it. We want your questions. Please give us your questions. Call in to 1-888-376-6225, or you can email them to questions@oncalltelevision.com. Give us that call, 1-888-376-6225. Do it early. We'll get your question on the air. Welcome you two for being on the show. Well, Carmen, you're from Esteline. You're right nearby.
Back at home, back at the alma mater.
And you moved from, you did SDSU, med school at USD School of Medicine, and then you did years of Chicago.
3 years in Chicago, finishing my dermatology training. A lot of variety of patient populations there, but skin cancer certainly prevalent all over the U.S.
Yes, it is. It is. And Jim, you've been around for a while and been on the show a number of times. But you did this training with Dr. Mose. Tell us a little bit about that.
Well, Dr. Mose was a surgeon at University of Wisconsin, and as a medical student, he was given the task of identifying a way to mark out cancers. And they assumed that they could paint something on the skin and it would show the cancer. Well, his research actually developed a technique for removing the cancer that made it possible to take out the cancer, look at it under the microscope, and determine whether it was present or gone. And so the technique essentially is especially helpful because it tells you when you remove the cancer, and allows you to remove the cancer with the smallest amount of tissue, but it also gives you the highest cure rate. And so it is a little more aggressive therapy because it takes a little more skill, it takes more laboratory things. The person doing the surgery is not only the surgeon, they're also the pathologist, so it requires some specific training with that. But it is the best way of removing difficult cancers.
The problem I've seen lately is that at some places, if there's a cancer on the face, a skin cancer, and I see tons of them, I scrape them off all the time, but now they come back from Arizona and they get Mohs surgery for little basal cell cancers, little actinic keratoses. It's a lot more expensive. Are we overdoing it? And I'm asking that, I mean, this is your world, and I know that's a touchy subject, but what do you think?
Well, I'm a South Dakota kid, so I'm a cheapskate, and my goal is when I treat a patient, I want to give them the best treatment for the least cost. And so in many cases, I'm doing exactly the same thing you're doing, Rick. I'm removing that cancer by a simple shave technique and a little curettage, and because I've been doing it for 35 years, I can do it with minimal scarring. But there are cases that are bigger and more aggressive and require the Mohs surgery.
Absolutely.
And what we have to look at today is we don't have an infinite supply of money. And so we have to judge when it's appropriate to use these more aggressive therapies, when is the simple technique available. And I think that's a real issue because a lot of young people come out of training where they're taught that you have this technology, you must use it, and so they're going to use it on every patient they see. And what we're doing with that is driving up the cost of health care, and it's something that we have to look at. And the best person to make that judgment, the doctor right there. None of us want somebody off in the corner saying you can only do this, you can only do that. So it's really incumbent on us doctors to make that judgment. What's the most cost-effective therapy for the person in front of you?
Carmen?
Yes.
Your comments on his...
You know, I think there's a time and a place for Mohs, but there are certainly other modalities to treat skin cancers. You know, cosmetically sensitive areas where you don't want to have a large scar, there's certainly Mohs plays a great role in that, but I think there's a time and a place for it.
I have a ton of 80-year-old farmer guys, and I've said, you know, well, we could, you know, there might be a better way to do this and have less scarring, and he says, nah. Just
get rid of it.
And I do it all the time, and it's been, when they come back, I send them to Jim McGrann.
Perfect.
All right, well, we've got some questions. I think we should just dive into them. But you know what, before we do that, I want to respond to something that we did last time you were here, not 3 months ago or so, Jim. So we were talking about barriers, and I'm a big fan of Vanny cream is a good, you know, a good moisturizing cream, and zinc oxide ointment doing a barrier job, and you said this is something well worth remembering, and that is that there is this thing called ceramide, and it's available now, not very expensive, and it's a wonderful cream, and it is a wonderful barrier, and we can use it, and it'll make a lot of difference. And so my wife Joni and I went to the grocery store, to the store, and we bought every kind of ceramide that we could find, and we bought Curel, which was relatively inexpensive, Curel Ultra Healing, and we bought CeraVe sunscreen and CeraVe hand cream and Amlactin Therapeutic, and these were versions of ceramide, and I've fallen in love with hand cream. What's your comment about that? Go ahead.
Go ahead. Ceramides are great.
I'll jump in a little bit. One of the issues we doctors have, especially dermatologists, is that we can give you that heavy, greasy medicine and expect you to use it, but the compliance issue is very low. Very frequently you give somebody and say, if you use this, it will work, and they come back and it didn't work. Well, you find out they put it on once, it was greasy, they didn't like it, it made my clothes smell, and I don't like it, and I'm not going to do it. So when they come back, they say, I tried it, it didn't work. The issue with the ceramides is it's extremely easy to use. It's not greasy. It's a very effective product, and at the present time there's enough competition to where the prices are wonderful. This product that we have here, amloctin, is a fabulous product, and for many years it was one of the few things we could use to treat certain kinds of skin disease. But the parent product costs something like $80. Now you can buy one of these ceramide products that has the same components and it's $10. Well, tell me which one's the right one to use. They both work. One's more elegant and it costs 1/8 of the other one. I guess I'm going to use the cheap one. And that's what the future is. There are old things, they do work. This simply works better. It's more cost effective. It's much more elegant, and we get better compliance.
So,
Compliance is the big thing.
Compliance. Will they take
getting
it?
to use something.
And a comment about ceramide. Your thoughts about ceramide?
I think they certainly help to restore that skin barrier, and keeping the barrier nice and protected and the way it should be. It helps with all types of different skin diseases, eczema, dry skin, all of those types of things. It's great.
Do you suggest putting it on right after moisturizing? I mean, after a shower,
after
washing your hands? I mean,
absolutely, and it works. Any type of moisturizing cream. To use it is the big thing. The second thing would be if your skin's still a little bit damp, it will help to push some of that natural moisture back into your skin and help to restore the barrier.
But the ceramide's best because it does have a really nice barrier to it.
It does.
I can attest to it. My hands are better because of it. Well, let's go right to the questions. Here is a question from Rapid City. Are olive skin people protected from some forms of skin cancer? The people who have darker complexion versus the Scotch-Irish, blue-eyed, perfect example of a guy who's at risk for skin cancer.
Well, when you look at it, the studies actually say yes, there is some protective factor. And when you look at people, say an Ethiopian who's got a dark black skin, they don't get quite as much skin cancer as the average individual. The olive individual gets a little bit less. But let's not be fooled. If you get enough, you're still going to get skin cancer. So I have an individual who is a ship's captain from Watertown, and I used to see him every 6 months. And he had a dark olive skin, swarthy looking guy, and you go, wow, this guy is going to be protected. He worked on the ship with the seas, and when he would come back, I would take off an average of 10 to 15 cancers every time I saw him. And yet this guy never really said he burned, yet he had huge amounts of sunlight being out in the open ocean, and that's the issue is, you're going to get maybe a little less, but if you get too much sun, you're still going to get skin cancer.
Do people who are out on water have more exposure to the sun?
You're certainly getting, reflection from the water. Snow, even here in South Dakota, and on winter days, people think they don't need to put sunscreen on because, they're not outside that much. But driving in your car, the reflection from the snow water, you're certainly getting increased UV exposure.
Yeah. Now, people talk about skin cancer, and there's kinds of UVA, UVB, UVC. Explain that to me.
So it all has to do with the wavelength of the light, and kind of, the majority of the UV is actually UVA. Studies will suggest that it's mainly UVB that plays a role in the development of skin cancers, but UVA certainly has a role. So that's why it's really important when you're looking for a sunscreen, you want to look for broad spectrum, that it's covering both the UVA and the UVB.
What about C? What's that?
UVC, that's, most of that's reflected by the ozone layer.
Okay. So then the other question has to do with the skin cancers are due to the UVB, right? And that's a smaller percentage. What tans us? Is it the A or the B?
It's usually the A, and that's what's in tanning beds. And so that's why some people will say that tanning beds don't cause cancer, but that's not true either.
Because there's B in there too.
There is, yeah. You're not getting a very specific wavelength of light. You're still getting that spectrum.
Okay. Comments?
Well, one of the things about light is that UVB penetrates to the epidermis but doesn't go through it. UVA penetrates lower, and so they're actually a more substantial damage when you treat areas and you have the UVA. And we know that melanoma incidence is higher very specifically because of the UVA from the tanning booth. I trained at University of Wisconsin, and we actually treated patients in research studies with a solar simulator, which used the various wavelengths of light, and what we discovered was there was an enormous damage potential from UVA. which at the original time was thought not to be the case.
So the tanning booths that say, we only have A, we don't have any B, you're going to be safe from it is not true. I mean, all of it is dangerous.
Well, it's a lie because first and foremost, the primary tanning component of the tanning booth is the UVA or UVB, which is a contaminant. They're selling the UVA, but the UVB is in there. And if you look at the newer tanning booths, they may have as high as 5% UVB. But then the second issue is if you looked at it and said, you know, I really like wrinkles, I want to get as many as I can. How can I do this? Well, the answer is very simple, tanning booth. Because it penetrates through the skin, hits the dermis, damages the dermis. Damaged dermis means wrinkles.
Do you have any good answers for wrinkles? I mean, some people talk about Retin-A. Do you use Retin-A to help people with wrinkles?
Absolutely. There's good evidence to support its use. Is it the end-all, cure-all? Absolutely not. I think your best friend is going to be sunscreen and staying and protecting yourself for wrinkles. If you already have them, Retin-A will decrease the appearance of fine lines and wrinkles, but if you have the deeper furrows, you're not necessarily going to get a whole lot of improvement with that, but it will help some.
It will. Doesn't it also help with pre-cancers?
Mm-hmm. Yep, it can help with that. It can help with some of the dark spots that you get from sun damage, kind of the brown spots or liver spots, as some people call them.
Okay. Yep. I've got a comment from Aberdeen. What is ceramide and how is it spelled? C-E-R-A-M-I-D-E. What the heck is it?
It's essentially a very low molecular weight oil. But a nice way to say it, it's a very small molecule. And so it's not a heavy oil, and it actually penetrates. In many cases, especially if you're using it on your hand, you go back and feel, you don't have that heavy area because it actually absorbs into the stratum corneum. And so that's because it's such a light oil, it does absorb, and that's why it's so effective.
Yeah, that's great. We have a call from Brookings. I have eczema and react to a wide variety of chemicals and can't even use lotion. Can I get a tattoo?
You can. There are certainly reports of people having reactions to the different colors of tattoos. So
it's a hypersensitive person.
I would be a little leery.
Yeah. Is that my son, Sean? No, Sean, you can't get a tattoo.
Tattoos are very popular, but a lot of people are looking for laser to have them removed because they, regret their choice of the butterfly or whatever they put on their ankle.
What about a person who has eczema and reacts to a wide variety of chemicals and can't even use lotions? Are there lotions for this person?
Oh, sure.
What lotion?
Lots of different things. Well, when you look at the issue, the primary thing most people are going to respond to is number one, the fragrance. So if you go unscented, that's a good start. But then if you're going beyond that, you can work with your dermatologist. They can test you to the various allergens. And most of the time, it's going to end up being a preservative. That's, if you're not a fragrance, it's going to be preservative. Once you know what you're sensitive to, then they can find various products. And Mayo Clinic has actually developed a group of products that are the Free and Clear and Vanicream and some other things that are free of fragrance, free of preservatives, free of the various things.
Vanicream is a good choice, then you would say.
So those are excellent products for people that are sensitive skin.
Very good. Brookings, I have a spider hemangioma on my face and have had it cauterized once and it's worse now. What else could be done to get rid of a spider hemangioma?
Do laser would certainly be an option for it where you're targeting that blood vessel. It's not completely painless. It does feel like a rubber band kind of snapping on the skin. Usually, sometimes you can get a little small amount of bruising in that area, but that's usually very effective for spider angiomas.
Didn't like the cauterizing. I'm thinking sometimes also tender. It hurts to get cryotherapy. The freezing. Freezing doesn't work for hemangiomas either. I've learned that one.
One of the problems with spider veins, which is what usually these things on the face is, that there is a single feeder vessel, and frequently when you cauterize it, you get the feeder vessel, but you got all these little tiny telangiectasia beyond it, and that's the advantage of a laser, is the laser will get all of them.
Okay, and that's how much money for a laser for?
It's the same charge for a laser as cryo, so it's it may cost us substantially more, but for the patient, it's the same charge as freezing.
Okay. We've got another call from Rapid City. This person has scaby, precancerous dark spots. In the past, he's had them frozen. Now his doctor wants to use topical Aldara. What do you think? The medicine is extremely expensive, this Aldara. So What about these precancerous dark spots and Aldara?
I think the topical creams certainly have a place if you have an extensive number of the precancer spots, instead of trying to individually feel and see each of those and freeze those with the cold medicine. You can talk about field therapy, where you're putting that medication in that entire area, in the whole field, and you're treating even those that you can't necessarily see or feel. They are very expensive medications, but they are very effective.
But Effudex, which is less expensive, also works, right?
Absolutely.
So that would be an option. But what about the price of Aldara, and what the heck is it?
Well, it's an imiquimod. It's a modulating medicine that stimulates your immune system, and when you apply it to the skin, it stimulates your immune system to target these precancer and cancerous cells. It's like any tool. We need it for certain patients, but you look at it and say, well, if a person has one actinic keratosis, it's more cost effective to treat that one spot with cryosurgery. If they have 100, we can do the job, but the issue is you may leave substantial scarring, you create a lot of pain, and it's difficult. But with what Carmen was just saying, the field therapy is something that we're finding more and more. If we can get to these people early on, use medications like Effudex, like imiquimod, then we can eliminate these lesions without the scarring, without the discomfort. And there are generic forms of this now, and so there are some help. The biggest issue is one of the things you and I have talked about previously, is that insurance companies determine whether you're going to be able to get it or not. So it used to be if the drug was generic, fine, you can get it. Now they're saying, nope, you can have 1B, you can have C, but you can't have D. And so really as doctors, we're not given all the choices. So a lot of times we're picking what the insurance company will give us, and that does sometimes limit the appropriate choice.
Yeah. While exposure to UV rays from sunlight is often the ignition to skin cancer, it may still arise in places on your skin that does not get exposure to the sun. We must be vigilant to watch signs wherever they appear.
I had it in 205, and I noticed that I had a small mole down here, which I hadn't noticed previously. Maybe somewhere in the 204, 205 it appeared. It's about the size, it was right down in there, and it's about the size of a rice grain. And then in the fall of 205 it began to look just a little darker and a little thicker, but it really wasn't growing so much. And I thought, I don't know. That just doesn't seem right. I made an appointment to see Dr. Park, the surgeon, and he biopsied it. Essentially, he took it off. It was that small. When I got into Dr. Park's office, I sensed right away there was something amiss, because he was uncomfortable himself. And he said, I think we need to bring Dr. Holm in on this. And I thought, oh my. And then he read the report to me. Comes back grade 2 malignant melanoma. I was very shocked. And even being a healthcare provider, I was very concerned about it, because I know a lot, and I've taken care of people who've had melanomas that have metastasized. And so I was very concerned, and immediately both of them reassured me that with that low a grade, grade 2, the chance of getting it all cut out was very high. So then Dr. Holm and Park sent me to Sioux Falls, and at Plastic Surgeons Limited, they gouged that out. They took a lot of skin around that area and then reinforced it. I had a skin graft in there, and it had to be done by a plastic surgeon. There isn't much there, so they actually took quite a bit out, and you don't have any skin to spare. So they took some skin out of my groin up in here, actually where they had gone in to test the nodes, biopsy the nodes, and patched it. And that was it took a month or so for that to heal up, but I have no trouble with it at all. They found no other cells. It hadn't gone anyplace, and in fact they didn't even find any cells anyplace. So they got all the cells out when they biopsied it. So the lesson in all of this is, one, you see something that doesn't look right, you think about it, you better have it looked at. And with melanoma, it's if it changes. begins to change, if the mole begins to change, like this I thought was getting a little darker, that's one of the times to really pay attention. And I was just lucky because I caught it so early and it hadn't spread into the cells.
Thank you, Dr. Peterson, for doing that. You know that she's retired provost for SDSU, and so I'm sure you're familiar with her name.
Absolutely.
A nurse, and now working full-time, caring for her wonderful husband too. So the question I have is, there it is. We're talking malignant melanoma as a result of exposure to the sun, but the sun doesn't go there. Why did it happen?
You know, there's certainly genetic things that play a role in there. Environmental, certainly, you know, other than sun exposure, can play a role. What else, Dr. McGrann?
Well, the biggest thing is field effect, or the field therapy.
Field effect.
Okay.
And so what we talk about is field therapy, and that is that when you see sun exposure, you don't get just skin cancer on the little spot that you get. You get damage to the immune system, and you have cancer cells moving. And so when you look at things, we dermatologists are most concerned about skin cancer showing up in non-sun exposed areas, especially on a digital area like this, because these are going to tend to be diagnosed late. They're going to be far advanced, and they're often, you know, this is an amelanotic melanoma, which many doctors are not going to even think of melanoma, and in certain cases pathologists wouldn't see it either. So it's a difficult one because it gets diagnosed late, it often doesn't get treated quickly, and they tend to be very, very aggressive. So she's a very lucky lady.
Well, she's a smart lady. She saw something that wasn't right. She went to her doctor and was referred to the surgeon, and the surgeon took it off, and then the path said bad. And she's alive now, 8 years later or something like that. And so it didn't get her. So the question is, malignant melanoma, why is it so difficult to diagnose and treat and prevent? I mean, what's the, you know, there's a whole story there.
You know, in most cases, it isn't difficult to diagnose. It's the issue that the patient doesn't come in until it's progressed. And so cure rates with melanoma has always been one issue. Early diagnosis, early treatment, cured. Late diagnosis, treatment not as effective, it's spread, and the cure rates are down. It's as simple as that. But you know, there are times when you look at it, and what I tell my patients is you only need to know one word, and that is, if something is changing, you should take a look at it. Now with the A, B, C, Ds, E, and S, and all these things, when you really get down to the issue, it's the key word, has it changed? And the smart person brings that to the attention of their doctor, and everybody says, well, you know, I can't see a dermatologist. Primary doctors are well skilled at looking at these things, and they can look at something, and if they say, you know, I don't know, then there's somebody like us to help them out. Right. But you know, when it's changing, be smart. Get it changed. Yeah. Get it checked.
Get it checked.
Remember to look in those areas that you don't think about. You know, for a lot of people, it's the back. It's hard to see in that area. If you don't have someone at home, use a mirror, and you know, there are different techniques to try to see those areas. Remember the buttocks, the genital area, between the toes, as we just saw on that. But the big thing is you got to be looking at your skin, looking for anything that's changing, as Dr. McGrann alluded to.
So I had a person who had what looked like an actinic keratosis, a classic actinic keratosis, scratchy, kind of a scaly area, and I froze it, and it didn't. It kind of came back, and then I froze it again, and it kind of came back. So today, he brought it in and he said, you know, it hasn't gone away, and I really wish that you'd do something more aggressive. And I said, okay. So we took the time, and we curetted it and sent it in. So we'll see what it is. But it curetted differently than an actinic keratosis, and I'm afraid that it might be something bad. And it's important to do that. When the old therapy, you know, if it isn't working right, if it's changing weird, I think that's it, the change.
Well, my rule is 3 strikes and you're out. So I'll freeze something twice, I'll look at it, but if I've done it twice and it hasn't responded, then I'm going to look hard at doing a biopsy.
Yeah.
One of the things we always teach doctors is when you're examining the skin, there's one sense that we're giving up way too often, and that is the sense of touch. And skin cancer has a thickness to it, has what we call induration. And so When you feel an actinic keratosis, it's a superficial, crusted, sandpaper-like thing, but skin cancer frequently has depth. So when you take your finger and gently palpate it, you can feel that there's depth to the tumor, and that's when you say, you know what, time to take this off. Don't freeze it. Don't do something else. Get a biopsy. See what's going on.
Right. We have pictures that we'd like to show. So let's talk about first the basal cell carcinoma, probably the most common.
Absolutely.
What would be the description of the basal cell carcinoma?
So it's usually, a lot of times, you know, it will look kind of like a pimple type lesion. It's oftentimes pink. Sometimes if it's very superficial, it can be a little bit kind of scaly. It can look like a little bit of a rash. It's a pimple that never goes away. Sometimes it itches. Sometimes it bleeds. Rough to the touch, like Dr. McGrann was saying.
It can be this shiny little border thing.
Exactly.
And
pearly.
It may have pearly border, right? It may have an ulcer. Or it may not have an ulcer. I had one who didn't have an ulcer this week. Then the next kind of cancer. Any other comment about basal cell?
Well, one of the things that I usually see with my patients is they're going to come into me and say, this is a spot that bleeds. When I get that word, I'm looking for cancer. If it's crusted, scaly, and it's not bleeding, probably a precancer actinic keratosis. But if it's bleeding, the majority of the times it's skin cancer.
And so let's look at the second kind, the squamous cell cancer. That's generally actinic keratoses, these scaly little things that turn to squamous cell. So tell me about this.
Well, squamous cell like this is a tumor that is a little more aggressive, gets a little deeper, it reacts a little stronger, and theoretically this is one that can go to other areas. What I tell people about this, the treatment is the same as the basal cell in the majority of areas. Once in a while, if it gets a little more aggressive, we go ahead and use the Mohs surgery. But typically where the risk areas with this kind of cancer is going to be if it's on the lip, if it's on the tongue, or if it's in the inner part of the ear. These are the ones where people die. When you look at squamous cell carcinoma, any other area in the body, we're probably going to be able to cure it.
But the lips and the ears?
Lips, tongue, and ear are the two areas where you may have a problem.
All right. We have a chance to do another package, but we're going to skip that because this is too good. We've got questions. Let's just, if that's all right with my team back there, let's skip the roll-in. So the next one is the issue of malignant melanoma, and that's the one that we want people to know can be anything and everything, and it can be pigmented, it may not be pigmented. So let's show that picture. Tell me about this, Carmen.
So when you look at that lesion there, it kind of follows those ABCDs that we talk about. It's asymmetric, so if you thought about folding that mole in half, the two sides wouldn't match up. B is border. It's irregularly bordered. It's not nice, smooth, round, regular borders. Color is C. That lesion there has multiple colors in it. The other thing to look for is it's changing color. It's a deep, dark black color. It's a different color than the other moles that are there. D that we talk about when we look at it is diameter, which is about pencil eraser size. With the picture, it's a little hard to tell exactly the scale there, but I'm guessing that one would probably be larger than a pencil eraser. And then the E, that's a thing for people to watch for, is evolving. It's new, it's changing, it didn't used to look like that.
And he talked about depth, when you could feel it.
Absolutely.
Describe what he's saying.
So, when you're kind of lightly running your fingers over that, melanomas, if we're talking about melanomas, they don't necessarily have to be raised up above the skin, but they certainly can be. Sometimes they can have a little, additional bump somewhere else within it, but there certainly can be melanomas that are flat to the skin. But when we're talking about the other types of skin cancer, feeling the skin is really important. I had a patient today. I often tell my patients these things are better felt than seen. That's why my hands are kind of running all over your skin.
Yeah.
And she's like, you look like a monkey, looking at my skin. And it's the first time I've been told that, but it's kind of true because we are
rubbing your hands
we're
over
certainly
their face.
touching.
Yeah. Certainly you can feel them better than you can see them, can't you?
Absolutely.
So the bottom line on those is that primarily something that's changing we need to bring, and it doesn't have to be pigmented.
Critical issue, because so many times people are looking at colors and they'll go, a mole is a brown thing that's changing. Well, not necessarily. And so that's why you look at your feet, you look at the other areas, and if there's something changing, it's smart to get that checked.
Now, do moles commonly turn to cancer or not?
Well, if we want to be statistical, 65% of melanomas occur in a pre-existing mole. So that means
yes.
35% will show up where there's never been a mole.
Okay, but more often.
More often than
from a
not,
mole.
yes.
And sometimes they do not have pigment. So how do you tell a malignant melanoma that doesn't have pigment?
Well, I think the answer is you're suspicious. It's changing, you do a biopsy. And I think that's one of the things that we teach medical students is if you're not sure what it is, you don't have to be a rocket scientist, but you do need to do a biopsy. And you send in a report to the pathologist and you say, this is a changing lesion. Pathologists have numerous tools that they can look at these that really helps them. But amelanotic melanoma is frequently a difficult cancer because it doesn't get recognized till late.
Okay. And one other thing, the most common thing that I see on people are these seborrheic keratoses. And I also see a lot of kind of what they say senile warts or warty growths on the forearms. How do you tell that these are something that you don't need to worry about, or that, you know, what's clues to a seb or a warty thing?
Sure. So we get a lot of people that come in for things that are the seborrheic keratosis or kind of that warty thing. Kind of the thing that looking at them when you have training and all of that, it makes it a little bit easier, but stuck on is kind of appearance. It looks like you could almost put your fingernail under it and kind of like flick it off.
And you can sometimes.
Sometimes you can, and sometimes patients have done that.
Yeah.
And that's a pretty good indication. There are other tools that we have in dermatology that we sometimes will use called the dermatoscope, where we kind of magnify it and put some light behind it, and then there are characteristic features that you can see with that.
All right. Well, we've got a ton of questions, and let's go for them. From Brookings, 72-year-old growth, forehead, size of a dime, sticks up hard like a bone for a year, bigger now than before. What do I do? There's no pain. So I'm thinking that it's hard like a bone, and it's been there for a year, and it's getting bigger than it was.
You got to go to your doctor.
That needs to be biopsied.
You need to have that checked. And biopsy is the answer. It may be something as simple as a seborrheic keratosis. It could be an osteoma, which is literally an injury to the bone. But until you have that examined, you don't know. And the longer you wait, the more difficult the solution.
Right. You both said go in.
Absolutely. Be seen.
Milbank, Merkel cell carcinoma on the cheek, rare. How can you explain it? What is it? Is it a different kind of squamous?
Well, Merkel cell is very, very rare. I've had less than a dozen in my lifetime as a cancer surgeon that I've treated. But it is triggered by a virus, and so it's a little unique that there's a virus in your system that triggers it. And it is frequently multicentric. So when the doctor sees it, they identify.
Multicentric meaning?
Well, it means it's in several locations. So it's not a single lesion. It may be in many, many areas. And so the doctor goes in and removes that single lesion. Your obligation is to do a wider exam. And in many cases, this is a person where you're going to have a multitude of therapies. A lot of times, by the time you've made that initial diagnosis, they have widespread disease in other areas. You may be using radiation, having an oncologist check them, and so one of the issues with Merkel cell is that's something where you need some specialty help.
I've had 2 patients with Merkel cell cancer, and
Really?
both of them did fine, but we got them early.
The thing about Merkel cells are almost always going to show up in severely sun-exposed areas, so
Yes.
face, neck, chest, like that, often on the chest of gals. They do look a little different under the microscope, and so this is one where I've had cases where they've been misdiagnosed, but Merkel cell requires the full services of what you've got.
I've had a number of keratoacanthomas, which are these really rapid growing little, and they look like squamous cell under the skin, and there are some who say, well, they're more benign than you think that they are. What's your comment about
There's kind of 2 camps with that in the medical literature. Some people think that they will just go away on their own and they aren't anything. I'm kind of the belief, and I believe Dr. McGrann would kind of agree, that they are more of a squamous cell and need to be treated and taken care of.
I'm glad to hear that, because I've been removing them going, wow, bad looking thing, and I've read in my textbook, oh, they'll go away if you leave them alone. I can't believe it.
Well, you know, that thing that may go away may be several centimeters before you decide that it ain't going away and now I can't treat it effectively. So these, in my mind, are clearly squamous cell carcinoma. They're rapidly evolving. They usually are easy to treat. There is a variation called Smith-Ferguson syndrome when these people have a propensity to get them, and that may be virally induced in that case. But the vast majority, there's a variation of a squamous cell carcinoma, and I think you'd be a fool to watch them.
And we've got a ton of questions, so we want to go fast so we don't miss any of these. Here is, how does the UV intensity of sunlight compare to tanning beds? What's the difference in the UV? And I suppose it depends upon the time of the year.
Well, you know, natural ultraviolet is a component of a little UVC, which usually gets filtered out, UVB, which is there, and it does matter from the time of the year. So in the middle of the summer, when the sun is coming directly down, you're getting a more intense UVA, UVB, and visible light, which is above 400 nanometers. When you get to the fall, the angle is cutting down, so you are getting a less intense UVB and UVA, but the whole issue is quantity. If you get enough of any of it, it's still going to harm you.
You know, you taught me one time, and I'd asked you to respond, Carmen. Sure. He said, if you are in the summer sun and you're sitting under a tree and you have a broad-brimmed hat, you have sun protective factor 2 on. I mean, it's not very much. We think that it's a lot. Well, I'm fine. I've got my sun hat on and I'm under a tree. Tell me about that. Carmen.
You're still, it doesn't filter out everything. You're still, you know, you have that intensity. You're at the peak time. If it's noon, you know, you have your peak hours of when the sun is its strongest. And, you know, to really get that, it has to be pretty tight weave. You have to do, you know, you still should have your sunscreen on.
So in other words, it's not a lot of sunscreen.
It's not there.
Anything about clothes? There are a lot of people selling clothes for sunscreen. They say certain clothes won't protect against the sunburn, and then some clothes do. Do you know anything about that?
So they do have some clothing out there that has been tested, and there's research behind it. And instead of SPF that you're looking at when you're buying sunscreen, it's called UPF, and that it has a number that's graded. It's a very tight weave clothing, but you would want to look for something with UPF, and it can be helpful.
So
I always tell people that's how you can tell the dermatologist kids, because when they're at the beach, the dermatologist kids are going to have the big floppy hat, and they're going to have these long, funny-looking clothing on, because they're the dermatologist kid. They don't want them to get that damage, and it does work. It is a little expensive, though.
One comment. I agree with the kind of spray. You have said that you like the fast sprays for sunscreen. You've told me in a different time. And you know, farmers are very reluctant to put cream on their face. But you can do this, and you get it. Any comments?
Well, you know, I've heard a lot of experts claim that that's not a good idea because you don't get it on. Well, my argument is some sunscreen is better than no sunscreen. And the only thing I do tell people, it's not a bad idea to take, you know, if you're a farmer, you can take out that hanky that's parked over here. And as a good Catholic boy, I still have my hanky too. But frequently what I do is when I spray it on, I'll take some kind of a tissue or something and kind of blend it to make sure I didn't miss areas. And you know, I've used sunscreen for a lot of years this way, and it does work for me. You know, but
I like it too.
Got to get it on.
I'll get it on. I mean, you can spray it on and then you can rub it in. That's how I work it. Here's from Sioux Falls. Is there an association of UV light with cataract formation?
Oh, absolutely.
Okay, talk about cataracts.
Well, you know, sunlight goes into the lens, and if you get enough damage, it becomes opacified or it becomes cloudy. Well, that's a cataract. When you buy your glasses, most of the time the optician is going to tell you for $4 more you can get a UV 400 coating. You really need to do that. Works pretty good. It isn't necessarily the color, it's that film that they can put on there. So glasses like you're wearing today can be absolutely clear and have a UV 400 coating, and it does protect the eyes. I can say as a patient, I had cataracts because as a young man, no one told me about sunglasses, and I spent hours out in the sun without sunglasses, and so in my early 50s, I had to have both cataracts operated because of that sunlight.
Oh, that sun exposure. So I had a question, and it just went somewhere. So, basal cell carcinoma. Ivanhoe, Minnesota asks, can't come back in the same spot, or can it?
Certainly can. Absolutely can come back in the same spot. You know, a lot of the modalities that we use to treat basal cell skin cancers have a very high cure rate, but there's always that potential. Did it come back in that exact same spot, or was there, you know, there's another one just appearing, you know, very close to where that was? But they certainly can come back.
All right. Rapid City. Are cirrhosis and eczema related? symptoms are decreased in the summer. Is this related to the sun? So cirrhosis and eczema and decreasing the symptoms.
Well, first we have to clarify, is it cirrhosis or psoriasis?
Oh, I bet that's what it was. It's psoriasis.
And cirrhosis, of course, is a disease of the liver, whereas psoriasis is an inherited characteristic where you have plaques of skin growing out. And then, of course, psoriasis is a form of eczema. And so I guess I'm kind of lost track.
So let's and I have no known association with cirrhosis and rashes. But there is an issue about exposure of alcohol and cigarettes and skin cancer, is there not?
Yes.
What is that association?
Absolutely. If you have a heavy intake of alcohol or a heavy smoker, you certainly have an increased risk of.
Do you have any reason, explanation, Carmen?
So you're getting mutations in the genes that kind of help with the division of cells. It's quite complicated.
All right.
The other thing is alcoholics aren't terribly healthy, so they don't have a good immune system, and a good immune system is what protects us against cancer. Cigarette smoking thins your blood vessels, reduces the blood flow. No question, you have a less effective immune system when you don't have a good blood flow.
Okay. Rapid City. So, is psoriasis and eczema the same thing? And how do you treat them? And what about the summer? I know if psoriasis occurs, one friend of mine, it goes away in the summer when he's golfing a lot.
Well, psoriasis is a form of eczema, but it's an inherited characteristic. And yes, sunlight does help it. I always tell my patients that before God invented dermatologists, he invented sunlight. But remember the same things that you and I have always talked about. Quantity is the issue. A little bit's good for you, too much isn't. So I tell my patients, yes, if you have eczema, if you have psoriasis, limited daily sun exposure is not a bad idea, 15 to 20 minutes. But more than that is clearly injurious. But when summer comes, we see certain things. Number one, you do get the ultraviolet light, but also the humidity has gone from 8% in your home up to 85%. So the increased humidity helps things. And then often in the summer, you're out doing fun things, and happy people have fewer problems.
Okay. Happy people have fewer problems. They do.
It's true.
You're happy and you're doing things, you don't itch. You don't scratch, you don't injure things.
Yeah.
So.
I like it.
Yankton, South Dakota, skin tag in the groin getting bigger and bigger, bothers him. Local dermatologist said he didn't want to remove it. What else could be done?
Certainly can be removed.
I removed those.
Absolutely. There's different ways to do it. You can freeze them with liquid nitrogen, the cryosurgery. Sometimes you can numb them up and snip them off.
Yeah.
It's an economic answer. Insurance companies won't pay you for removing skin tags. So the reason why he doesn't want to remove it is because if he takes it off, he won't get paid for it. And so the simple answer is, in most cases, I'll treat other conditions and take the skin tag off as a courtesy because I'm not going to get paid. I just do it.
That's right. There's where I'm at. Here is Mitchell. Comment on today's bathing beauties or tomorrow's shriveled prunes.
Absolutely true.
Absolutely.
Yep. Yeah. Okay, Sioux Falls. Caller is very uncomfortable with having skin checked. Is there a way that doctors can make it less intimidating? That's a really good question. How do you make it easier for people to, some people are very modest.
Absolutely. I always say I haven't invented, my x-ray vision hasn't been perfected yet, so to really see it, we do have to see the skin, but you try to keep them, clothed in the areas and focus on certain areas.
I try to use the cover and cover the areas.
Absolutely. And, don't make them sit there completely naked.
If you make a patient come into your room, take all the clothes off, they're going to be uncomfortable. Absolutely. So if they can wear a gown, if you can use a sheet, exactly what you're talking about, you don't have to examine the whole thing at one point. You can look at the legs, you can look at other areas, you can keep the other important areas covered so that they don't have to feel like they're being humiliated.
All right, so we've got 20 seconds. 64-year-old with hypothyroidism has lesions all over the body, which his doctor says is related to hypothyroidism, and it's just dry skin. What should he do, and does he need to see a dermatologist? Dry skin?
Yep, see a dermatologist.
You said yes.
Could be myxedema, could be other things. You need to see a dermatologist.
All right. Well, we'll be back right after this.
Think you found every hazard out here today? Think again. The spot you missed could be a killer. That spot on your skin could be skin cancer. If you're a man over 50, you're in a group most likely to develop skin cancer, including melanoma, the kind that kills one person every hour. That's why your best shot is to check for a spot. It's easy. Follow through and check your skin. Go to spotskincancer.org to find out how. A message from the American Academy of Dermatology.
Life often requires balancing good with the bad. Many Dakota Prairie people have had a lifetime of soaking in the sun while putting out the wash on the clothesline, planting and cultivating corn, harvesting wheat, or putting up hay. And don't forget sitting on a boat waiting for the walleye to bite, or hitting a little white ball around trying to put it into a hole in the ground, or lying on a towel feeling the warm rays console after a too long Dakota winter. It turns out that all those rays from the sun do something very good and important for us, but at the same time do something that can be very bad. First, the advantages. Exposure to the sun allows for melatonin level swings that encourages a good night's sleep and a positive mood. Also, the sun provides for the natural production of vitamin D that stimulates calcium and phosphate regulation, which in turn encourages bone growth and proper remodeling. Although not proven, vitamin D is thought to be important also in cardiovascular health, cancer prevention, elderly falls reduction, immune function, all bringing reduced death rates. We need more data to prove these last theories, but to sum it up, not only do plants need the sun, but humans do too. Scientists say that north of the 42nd parallel, or about at Omaha, the sun's energy is insufficient for vitamin D synthesis from November through February. Related is the condition we experience up here called seasonal affective disorder, or the winter blues. It's a real depressive condition due to not enough light, treated simply by giving those affected more exposure to the beams of the sun or another strong source of light. On the other hand, there are disadvantages to too much sun, especially in those light-skinned, red and blonde-headed, blue-eyed, Scandinavian, German, Scotch-Irish type. UV radiation is toxic to the skin, and it's the lifetime exposure that counts up. I see the ravages of old soul on the face of my patients with premature aging and cancers of several types. They come in with excessive wrinkles, sores that don't heal, scales that turning into little horns, and pigmented spots that are spreading. How can something so good be also so bad? Well, bottom line, enjoy the sun, but balance with sun screening, checking vitamin D levels, and seeing your doctor when that skin bump changes. Well, kind of summarized it. We didn't give the sun its fair shake. I thought it was worth commenting. So
yeah,
you spoke about the sun doing good things.
I'd give you an amen on that.
Absolutely.
You know, there's good and there's bad. You know, you have to go into it with some common sense. You know, in the old days, we were all outside. Our mom said, go on out and get some sun. We did. We didn't know it was that she wanted us out of the house, but but we did, and that's why, you know, years later we're having these issues, because we did get a lot of sun. There weren't sunscreens. We're the generation that are showing our younger people what happens when you don't use the sunscreen. But like Carmen grew up in a generation where they said use the sunscreen. So you look at her, and here's a lovely lady, and then you look at me at a grizzled old beach.
A grizzled old poop,
yeah.
So Carmen, your take on the sun?
You know, I think it all comes down to, as we've alluded to multiple times, quantity. You know, a little bit of anything's fine, but not for long periods of time. And just check your skin. That's the big take-home message. Anything that's changing, got to show someone.
Well, and I take that issue of the joy of having the sun after this long South Dakota winter, and April being a terrible month in many ways. Hallelujah that we're coming to a change.
Yes.
And what a joy to have the two of you here. Thank you so much for joining us.
Thank you, Rick.
This brings us to the end of our show this evening. I sincerely thank our studio guests, dermatology physicians Carmen Schwartz and Jim McGrann, for helping to answer all the insightful questions from our audience. Truth is like the sun, according to Elvis Presley. You can shut it out for a time, but it ain't gonna go away. Until next time, stay healthy out there, people.
Funding for On Call is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call, starting its 11th year of opening doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.